Today, I am thrilled to be joined by a guest I've been dying to talk to since starting the podcast, Dr Corinne Menn. Based in the US, Corinne is a board-certified OB-GYN, Menopause Society Practitioner, and leading expert in women's health. As a breast cancer survivor and BRCA2 gene carrier, Corinne experienced a very early menopause and brings a highly personal perspective to her work, with a key focus on the intersection of breast cancer, menopause, and premature ovarian insufficiency. In this conversation, Corinne sheds some light on the unique challenges women experiencing early menopause or menopause after cancer face. We discuss exactly what premature ovarian insufficiency means, the risks and benefits of MHT for cancer survivors, and unpack its probably unfair reputation of being linked with cancer. Corinne was so generous in sharing her knowledge and personal story, and I hope this episode helps anyone out there who's struggling. Let's get into it. I'd love you to tell our audience a little bit about you and how you've ended up with such a specific interest.
Yes. So I'm a board certified OB-GYN and a Menopause Society certified practitioner, practicing for over 20 years now. And back in 2001, when I was a second year OB-GYN resident, I was unfortunately diagnosed with early stage breast cancer, stage 2, only a month or so after my mom had passed away of ovarian cancer at a very young age. I was newly married. I was only 28. I was shell-shocked and not prepared, certainly, for that cancer diagnosis, but then certainly not prepared for all of the collateral damage that came from that, including early menopause that I went through not once, not twice, but 3 times. First 2 times temporarily from various treatments, and then finally when I had my ovaries removed to lower my risk of ovarian cancer. And it was then, because during the midst of treatments, I was kind of just muddling through trying to be a busy OB-GYN in training and dealing with treatments. Finally, when those ovaries were removed, I realized, wow, I do not know how to take care of the average woman in menopause, much less a younger woman like myself or a woman with complicated medical history. And I realized my medical training did not prepare me whatsoever to deal with a lot of the common things that we see in everyday women's healthcare practices. And that's when I kind of started to change my direction and focus on breast cancer and cancer survivorship, but also just perimenopause, menopause, sexual health. Got involved in the Menopause Society, and then eventually with ISWISH, the International Society for Study of Women's Sexual Health, and now practice exclusively via telehealth in a private way, as well as with Alloy, which is a menopause telehealth company here in the US. So that's what I'm doing now. I'm doing a lot of teaching for other doctors and other breast cancer survivors to try to level up the knowledge. But it's kind of a third rail, breast cancer, hormones, menopause. So yeah, it's been interesting.
Yeah, absolutely. So that was horrendous, obviously, having only lost your mum and then having that diagnosis. Did you guys know at that stage that there was a genetic element to your mum's cancer?
No. So, remember, this was 2001. So the BRCA1 and 2 gene was just kind of coming into kind of clinical relevance, right? And at the time, they didn't even encourage me to get genetically tested. I actually waited about a year to get tested because at the time, it wasn't changing my surgical management. I was electing to have a bilateral mastectomy at the time and hadn't had children yet. So we did fertility preservation prior to chemotherapy. But, oh, my doggy just walked in. He's behind me here. He might come into screen. And so, yeah, they didn't really encourage me. And then I got tested and it was negative. And it never sat well with me because I was only 28. My mom was 54 when she passed away. And I always said, oh, there's something not right with my genes. They just haven't identified it. And I was right. So always listen to your gut. And then years later, when I was opening up my own private practice and kind of making sure I was really up to date on things, I realized I needed to update genetic testing. And so I demanded to get my BRCA1 and 2 gene retested. And sure enough, the large rearrangement of the gene, or the BART sequence, was not considered standard of care before 2013. And nobody recalled me and said, hey, you need to update testing. If it wasn't for me investigating on my own for my own clinical practice, I would not have retested myself. And I do carry the BRCA2 gene, which is really impactful because now other family members have been tested, are positive, and are making management decisions. And so that was one example of where women have to be a squeaky wheel, right? And it really, impacts things. And so that's another area then that led me to kind of specialize in is kind of the unique needs of these cancer previvors, which is a growing group of women, right? And men, because we're identifying more and more genetic mutation carriers.
Yeah, so look, that's and also a personal interest of mine. So I'm a BRCA1 person. I've had bilateral mastectomy, oophorectomy at the cesarean of my fourth child. So went from pregnant to menopausal, and then, to be honest, spent the next 10 to 12 years having lots of symptoms because I was strongly encouraged not to take hormone replacement therapy after that.
Like that's my blood boil when I hear this story, because you were probably younger than the natural age of menopause.
Oh, I was
correct?
33, and so it was, and I spent the next 10 years putting everything down to, oh, I've got 4 children, or I've got a busy job as a doctor, oh, I'm blah 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 blah, and I think I only started sleeping probably in the last, I don't know, 18 months when I actually went on to hormone replacement therapy. But what I'll also say is I look back and go, how did I not even personally piece everything together? I kept putting out all the symptoms down to other things. Oh, it must be because of this. Or like I'd had 3 children prior to that, and I'd always, for example, been able to get back to my normal weight. But then with my 4th child, when I went from pregnant to menopausal, I just could not seem to get back to my normal weight. I seemed to keep putting on weight. I went from having a cholesterol that was really below normal to a high cholesterol. And it was, I look back and I'm so frustrated at myself as well, because I think, how could I not see what was going on?
And can I ask you, did you have your bilateral mastectomy at that point already?
Yes, I did. So I had a bilateral mastectomy.
And they still didn't give you menopausal hormone therapy. It's frankly, it's medical malpractice to plunge a woman into premature menopause without counseling her. That's estrogen deprivation, and she needs full hormone replacement therapy. Yes, HRT replacement therapy up into at least the age of natural menopause, particularly when your breasts were already removed. What were they protecting you from? That's insane.
It was one of those conflict scenarios where I think everyone in the team looking after me was really stressed. At that point, I still lived in Ireland. It was a very small community. I'd had a number of family members who had died. I'd had a cousin who was 27 who'd had breast cancer, all the things. And it was a small group of clinicians who'd looked after multiple family members. And obviously, I was a doctor. I'd initially started off in surgical training, so lots of them knew me quite well. I think they were really scared of something happening to me. I don't think it was done in any way sort of vindictively, but it was very much...
No, it's not. No, it's, and also lack of knowledge.
Absolutely.
Listen, it's 2024 now, and I'm in the New York City suburbs. So I see referrals of women who are BRCA1 and 2 carriers who are being treated at the most famous cancer hospitals in the world. And they come to me with the most ridiculous statements that their doctors have told them that go actually against the current medical guidelines on how to manage BRCA carriers who have had prophylactic oophorectomies, regardless of whether they've had their breasts removed or not. Hormone therapy does not negate the lowering of their breast cancer risk by having their ovaries removed, which is super interesting. But the data is there, and it's pretty clear. And that, hormone therapy doesn't further increase their risk if they have intact breasts. Once the breasts are removed, yes, we don't remove every last cell of breast cells, but the risk is incredibly low. And, I think it's just, I just did a reel, and it's like Dr. Mary Claire Haver, she did it, and now a bunch of other clinicians are doing it on Instagram, saying I was a bad menopause doctor, and say like why we were bad menopause doctors and what we did different and how we learned, right? And we all learned from either our own medical experience or from like a patient that just happened to really impact us. But none of us realized that we were such bad menopause doctors because someone in our medical training told us that. In fact, they taught us to be bad menopause doctors. Really.
I agree. I think 2 things. One was I was told try and battle through as best you can. But if the hot flushes get too bad, then you can have hormones. Well, I actually have never had a hot flush ever. So that was very interesting. And I think the second thing is that, I probably, like you, was in the era of the WHI. I worked in the UK at the time. We were literally given massive call lists of patients to phone everybody up and get them all off their HRT. So, I look back and say, was a really terrible menopause doctor, because I was the person, 20 years ago trying to talk you into stopping your HRT. So, it's definitely gone full circle. And people often ask me, why do I think, the menopause and perimenopause is having a moment, not, now, why is everyone talking about it? And I kind of think it's because there's a cohort of female doctors who've all matured to a certain age, and that's coincided with also a cohort of female doctors who've maybe also had things like breast cancer or genetic cancers, which have given them very early menopause. And then I also think it's a collision with social media, because I can't really understand it otherwise.
You're exactly right. I think it's the first time in history that we have enough women in positions of power, of leadership, whether it's in the media, in certainly medicine, and we're coming of age. And so we're talking about it. I mean, even our cohorts of like women who are like, women who are just maybe 10 years older than us, 15 years older than us, they are not really necessarily on social media, right? So a lot of those menopause clinicians that I've now learned from, they just didn't have the platform to spread the word. And there weren't their counterparts at the New York Times that were actually interested in hearing about menopause. That was like not sexy. But now when you've got like, editors and stuff and these journalists who are also, like you say, going through these things, they're like, hey, I mean, that's Sue Dominus, who was the author of the New York Times, Women Have Been Misled on Menopause. And I always add, and so have doctors. It was because of her own experience and her friends, that she started to do this investigative reporting on like, heck, what happened with this WHI, And I always laugh. I think like, my goodness, like, did anybody even read the WHI study? Like, no one even read it. They just like everyone got just like the bullet points from like NBC News.
The sound bites, and then everybody ran with the sound bites, and you kind of look back in hindsight.
They would have realized like, oh, wait, it's really, no. Like we need to like, there's a lot of more nuance, but I actually think no one even read it because many of the doctors didn't have access to even the article unless you were a subscriber to the journal, right? It wasn't like we could just like go online and pull up the journal and read all of the details and read all the commentary. It just wasn't like that. Medicine was passed down, like the ethics were passed down in a different way, It's much more, the information is much more democratized now.
Isn't it interesting, though, that I think that it continues to be so hard for hormones to shake off this reputation of being connected with breast cancer. And, it's just still with clinicians. I had a patient who I saw recently, and, we've started her on hormones. She had lots of mental health issues that were not improving. She was on so many psychiatric medications and antipsychotic, et cetera, and she has really improved dramatically on some hormones. But when she told her psychiatrist that I had started her on the hormones, they told her that that was really dangerous. And so it's so frustrating. And, even next week we are having an education event for clinicians, and we're going to have like 6 speakers. And what's been really frustrating is that I feel like the people who are attending actually are the people who already know quite a lot. And it's hard to get the clinicians who are, not really up to date to come, because they say, oh, I'm not really interested in the menopause and things like that. And even I did send it to, an allied health professional who I know, encouraging him. And he said, oh, well, I'll send it to the female physios. And I'm so frustrated. It's like, I want you to send it to everyone.
Well, you're exactly right. And like, we kind of sometimes live in an echo chamber of, like-minded physicians and clinicians. And I think that, we really have to, and the leaders in the different medical menopause societies need to like really start to like show up at like the family practice and the internal medicine annual society meetings. They've got to go to the hospitals and do grand rounds for everybody, because this is not just relegated. This is not a niche. When half the population enters menopause and it affects every single body system and every single organ system, it's unconscionable to be a rheumatologist or an orthopedic surgeon or a psychiatrist and have no knowledge of what is happening during the menopause transition to your organ system. It would be like a pediatric rheumatologist not to have any idea about puberty and how it affects joint health. And so, how do primary care doctors, internal medicine doctors relegate this to niche medicine? It's really misogynistic, and they don't mean it to be, but it's these preconceived stereotypes of what does women's health mean, right? And it's it can be demoralizing. So I understand that you put good effort into doing these speaking engagements, educating, and then you're like, wait, I'm just educating my followers. They already know this. Yeah.
Absolutely. It's so frustrating. Okay, so what I'd love to dive into with you is premature ovarian insufficiency and early menopause. I think a group of women who really are ignored, who are told, oh, you're too young. And I'd love you to, if you don't mind, go back and let's go through what the definitions are and who these people are.
Yeah, of course. Yeah. They're the most vulnerable women. And I say they have the most to lose and the most to gain if we help them. And it's really tragic because it's actually not controversial in how to treat these women. We have very, very clear guidelines that have been there for decades. And so premature ovarian insufficiency, the more modern term, we used to call it premature ovarian failure, kind of a large term that incorporates anybody having early menopause under the age of 40, but between 40 and 45, so even under the age of 45 is considered earlier menopause, but true premature is 40 or under, can be caused by a lot of things. It can be um, genetic causes, chronic medical diseases, certainly cancer treatments, removal of the ovaries for benign reasons that are not cancer, like endometriosis, for lowering cancer risks and hereditary cancer, things like Turner syndrome, which is a genetic mutation. So there's lots of reasons why it can happen. Some of the premature menopause is permanent. Others are can be temporary, like when you're going through treatment, like me. And so I had many years without estrogen, but then hormones came back when I stopped certain treatments. But then, finally were, taken away again when I had the ovaries removed. And so in these cases, the reason why it's so important to talk about it is while there can be a variety of reasons why someone can find themselves in premature menopause, we know regardless of what the reason is that got you there, we know what the immediate as well as long-term extremely negative impacts on your overall health. Like over 95% increased risks of cardiovascular disease, stroke, dementia, arthritis, osteoporosis, mental health, issues, sexual dysfunction, urinary issues, and just the list goes on. But the most serious risks really involve these that are the big killers of women, right? Cardiac disease, right? And then next is osteoporosis and dementia. And we have very clear guidelines that these women need full physiologic levels of hormone replacement unless there's a true contraindication. So that's where sometimes things get kind of lost in the shuffle, right? So when we're talking about full replacement, we mean we're trying to mimic what would naturally be happening with your ovaries, right? So, really restoring estrogen levels up to that physiologic level during your reproductive year. So that would be using like a 2 milligram of an oral estradiol, or the highest dose of the estradiol patch is 0.1, or sometimes even higher doses. And those are the cases where we actually may recommend keeping an eye on serum levels just to make sure that they're absorbing and we're replacing enough so that we know we're protecting them. And then once they reach that average age of menopause around 51, we can have the discussion of like, okay, would you like to continue? Yes, probably. Or, not. But, at the very least, we need to get you up to the natural age of menopause. And we shouldn't be ignoring progesterone and testosterone. So if you still have a uterus, you have to also replace the progesterone, because otherwise estrogen given without progesterone could cause uterine cancer. But we also need to think about testosterone. These women are not meant, particularly the ones who have lost their ovaries, they're not meant to have lost 50% of the source of testosterone production in their bodies at such a young age. And testosterone, particularly for these younger women, it's not just about sexual function, although that's extremely important, but testosterone, has functions throughout our body, our brain, our bones, literally every cell, right? And so that's another part of premature menopause that often gets, ignored. And then the other thing is that many of these women are told that they have a contraindication when they don't. You're a great example, right? Or other examples are patients who have had treatment for endometriosis. And while we're certainly cautious giving back estrogen to make sure we're not like re-stimulating any endometriosis, these women can safely often get hormones back, and you do it in the right way by also adding progesterone in those cases. And then there are women like me who are told absolutely not, or we are taking anti-estrogen medications to prevent breast cancer recurrence. And so, that's something that I'm super passionate about, because while there are some patients who, like for a number of years for me where we could not use hormones, well, then we better address the big pink elephant in the room of, well, what are we going to do about you being 28 and now having no hormones? And we really need to help you with all of that collateral damage. So whether we help you hormonally, which is obviously what is preferred in most cases, but if we can't, we must then help you in other ways. And sadly, that doesn't even happen. So, when I talk to my patients who are breast cancer survivors, particularly with estrogen receptor positive breast cancer, but also with estrogen receptor negative breast cancer, I ask them, like, has anybody offered you anything even non-hormonal for your hot flashes? And like less than half of them tell me no. Has anyone done a bone density? No. Has anyone discussed increased cardiovascular disease? No. Is anybody giving you local, safe vaginal estrogen options to treat your genitourinary syndrome of menopause? That is very impactful. You know, 9 times out of 10, it's just maybe one, just very few women will say yes. And it's really, that's very devastating to women. And it's kind of my biggest passion, because if we were cutting off the testicles of 28, 33-year-old men and telling them, have some lube, here's an antidepressant, see how it goes. I mean, we would have anarchy. We wouldn't do that, but we do it to women, millions of women every day, due to treatments of a variety of medical conditions. And I'll never argue that my breast cancer treatments were important, and I took tamoxifen for over 10 years, and I had ovarian suppression, and I'm cancer free, and I'm grateful and all that. But nobody along the lines discussed with me what that actually meant.
Do you not think there is a bit of an attitude around breast cancer and female cancers that, I feel like sometimes my patients will tell me that they've been given the vibe or the feeling is that you should just be really grateful that you don't have breast cancer anymore, or aren't you really grateful that we've done this sort of treatment for you, and this is your lot, like you just have to put up with all these horrible symptoms?
That is the sentiment. And I don't think the sentiment is listen, I'm really respectful of my oncology colleagues. They do very, very hard work. The medical system here in the US is not ideal for the practice of medicine. They're under tremendous pressure to see lots of patients in a short amount of time. The field is constantly changing, and they have to stay up to date on a lot of new cancer things. So I respect that they're not menopause experts. But if you are the person who is prescribing the treatment that is causing severe collateral damages, you better damn well know how to address those damages, even if it means you're sending them to referral to a menopause specialist or an osteoporosis specialist or someone who really understands nutrition and exercise. You can't just send these women off on their way saying, like, eat a little less, exercise a little more, and here's some Prozac. Like, that's not acceptable, right? And so, and patients feel grateful too. And so it works both ways. I think the doctors are like, listen, I cured your cancer. Like, this is not my cup of tea. Like, I don't really deal with this. Just be happy. Like, I take care, and a lot of oncologists said, well, they say, I see the women with stage 4. I see the women dying. Like, you don't want that. Like, I'm not going to deal with your complaints about a dry vagina, right? And then on the other side, the women I feel like are very often nervous to even tell the oncologists the full extent of their suffering because they don't want to be seen as a complainer. They want to be seen as someone who's a fighter or survivor, that they're tough, that they can handle it, and that they are grateful. And they are. They all are. But it's interesting because I'll tell, like, patients will see me and I have like an intake form and I get like, it's very comprehensive and I give them space for all their concerns and I really break it out. And a lot of them realize like, oh my goodness, I didn't even realize these things until you asked them, right? They didn't think that was part of menopause. They thought, and so, or something that they should be concerned about. And so I look at their intake form and then I say, well, have you told your oncologist this? And they're like, oh, no. Like when they ask me how I'm doing on the aromatase inhibitor or how I'm doing after my, ovary removal, I just say, oh, I'm okay. I'm not sleeping the best. But and they say, oh, stay off your phone, you know, like, try to get regular good sleep habits. And that's it. I'm like, well, I think that, it's also on the patient. Like you have got to, if you expect help, you have got to speak up and not be shy and not take that attitude of, I just have to be grateful. Because I say, if you showed your doctor that list and it was written in a clearer, professional manner, it would be really hard pressed for them to ignore it, right? And if they did, you could bring it up and say, can we have a special appointment to talk about this? Because I understand you're busy with my routine follow-up. And if they still don't address it, then it's your sign you need somebody else, right? But women often don't share the full extent. And a lot of oncologists I talk to say, oh, my patients deal pretty well with their aromatase inhibitors. I'm like, oh, do they? Are you asking them actually how they're doing? When you ask them, does it hurt, any problems, any pain with sex? And the patients say no. But when I ask them is when the last time you were able to have intimacy? And they're like, oh, I haven't had sex with my husband in 4 years because it feels like shards of glass. So when you say, do you have pain with sex? Because I'm not having it. Or, they don't even, or there's other things that they don't realize, for instance, are part of the genitourinary syndrome. They don't ask the patients, are you peeing like multiple times a day and you have urgency and frequency and, you have a relationship breakdown. I mean, these are the things that don't get asked.
For many years in my GP rooms and with friends and family, I heard the same story. People feeling overwhelmed with a huge array of skincare products on the market. Fears around having sensitive skin, choosing the wrong product, or being sold something they don't need. There are so many people intrigued by the latest trends in anti-aging treatments, but unsure if that would be relevant or actually even help them. And many are feeling afraid of being left looking different, silly, or even having an adverse reaction. As a doctor of 25 years, and of course as a woman experiencing the signs of aging myself, I am proud to have created WHI by Dr Shauna Watts clinics. Led by myself and an experienced team of doctors, our goal is not to change you, just help you become the most confident version of you. Every journey at our clinic begins with a comprehensive assessment by our doctors and includes photography, skin analysis, a thorough exploration of your medical history, and of course, time to chat about your concerns and desires. Together, we create a completely customized plan, helping you achieve the confidence that you've always wanted. We treat all skin concerns, including redness, acne, pigmentation, sun damage, and all signs of aging. We take a holistic approach and only include evidence-based therapies. So if you're ready to start prioritizing you and exploring what we can do to help, please book in for a no-pressure Planning Your Aesthetic Journey appointment. You will leave with a full written plan and information on any recommendations. Our clinics are based at Foresters Beach and Newcastle, and you can book online at whybydrshaunawatts.com.au. Corinne, I've heard you explain about estrogen receptor positive and negative, and I love your explanation because I do feel like people get very confused about that, and even I think doctors do as well. There seems to be this thinking that people say, oh, and my breast cancer was caused by estrogen. would you be able to explain that to the audience? Because I think it's so helpful.
Yeah, this is super important. I think we start with understanding that there are estrogen receptors on all the cells of our body. Okay. So our brain, our GI tract, our breasts, our bones, every cell, our skin. And so, normal healthy breast tissue has estrogen receptors on it. Okay. And, listen, this estrogen helps your breasts grow, right? Like your estrogen levels rising when you're going through puberty is what, causes you to have, become a woman and have breast tissue and be able to one day breastfeed if you have a baby, right? So estrogen, yes, is, integral into breast function and growth and healthy breasts, right? And so when women get breast cancer, we're able now to do this testing to look deep at the cell and see, well, as this cell has turned from a normal looking cell to a cancer cell, what does it look like? Is it look really similar to a normal healthy breast cell? And typically that's when we call that a low grade or a well differentiated breast cancer cell. And those cells generally, typically a lower grade or, well differentiated breast cells often still retain the estrogen receptor. So there's still the receptor there. So the cell hasn't gotten so abnormal that it's lost its receptors or its ability to express estrogen receptors and progesterone receptors. Um, and then there are some breast cancer cells that when they look at it, they say, oh, this cell's changed a lot and it no longer even expresses the estrogen receptor. So what does that mean? So it means that, it's about 80% of the time that the cells actually keep their estrogen receptors. So that just means that there's some cancer cells that still show estrogen receptors, which then gives the oncologist a tool to help control that cancer cell by either blocking or manipulating, degrading, doing things to that estrogen receptor. But the oncologist has other things they can do that for that cancer cell, right? We now use immunotherapy. We use radiation therapy. We do surgical things like we cut out the cancer, we burn it, we manipulate it by modulating the estrogen receptors. Now, when breast cancer cells have no longer showing the estrogen receptors, that's when we call that ER negative, often triple negative breast cancer. So we can't use any manipulation of hormones to help control that cancer cell. That is a very, very different understanding, and that's what it is, than saying the estrogen receptors means that estrogen caused your breast cancer. So then what does it mean when we have estrogen receptors in our breast when we're born? Or your 16-year-old daughter or your 55-year-old husband, he has estrogen receptors on his breast, right? And so I think the receptor is just one marker, one bit of appearance on this abnormal cancer cell. And it does not mean that estrogen caused your breast cancer. And in fact, in the vast majority of breast cancer cases, there's either some environmental issue, some genetic thing. And I don't mean that it's a hereditary genetic thing, but, there can just be a DNA repair that our cells are always repairing. And, our immune system is keeping things in check. And sometimes things go awry. Why do they go awry? We don't know exactly, but most breast cancer is not related to hereditary mutation. It's spontaneous and probably impacted by lifestyle, environmental exposures, diet, nutrition, exercise, all those things, and just bad luck, right? And then there's a small percentage that are due to genetic influences. But the vast majority of data shows us that menopausal hormone therapy, birth control pills, is not associated with a significant increase in breast cancer risk. But unfortunately, I feel like it's a lot easier to just tell a patient that estrogen causes cancer. And that's it. It's just easier than explaining all of that.
Yeah, absolutely. But it's so frustrating because then people end up blaming themselves. I've patients tell me
Yes.
all the time, oh, my mom had breast cancer, but, she took HRT and now she feels so bad because she thinks that she gave herself breast cancer. And it's It's so frustrating.
No, and what's really frustrating is like, listen, what caused that fear was a Women's Health Initiative, and we don't ever, even when it was released, no one ever did a press conference explaining that women who took estrogen alone in that study, right? Women who didn't have a uterus, they were given only estrogen. They had a 23% decreased risk of getting breast cancer and a 40% decreased risk of dying of breast cancer. And the risk of women who were taking the combination of an estrogen with a synthetic progestin, which we know has a little bit more negative probably impacts on breasts in general, the synthetic progestin, they had a tiny, when I say tiny, I mean tiny increased risk of being diagnosed with a non-fatal breast cancer. And even that number is debated because the statistical methods and the way it was reported is, has been argued. But let's take it at face value. I was just speaking at a conference and there was 500 women in the room. And so I told all the women, look around you and double your numbers. Make this room double. Picture the room to have 1,000 women in it. And then I asked one woman to stand up. And I said, see this one woman in this room of, we're imagining 1,000 women. That is the extra increase person per every 1,000. So it was actually less than one, so 0.8. But let's just say 1 per 1,000 women were diagnosed with a new breast cancer versus those who are on placebo. One extra person. But that woman wasn't more likely to die of her breast cancer. And it's so when you put it in that perspective, you realize like, oh, it wasn't some horrible number. I'm like, no. And to make it even better, if she didn't take the progestin component of it, there would have been less women getting breast cancer and less women dying of it. So that's a whole lot different than like telling everyone that HRT causes breast cancer and causes you to die of breast cancer, And like, this is not really rocket science numbers here. This is basic statistical reporting. And the data's been there. So everyone's like, oh, the WHI has been updated. I'm like, no, that data has been there since day one. And so it's not new news, unfortunately, but it is for most people.
Yeah, it's so frustrating. So, Corinne, what I'd like to ask you is, what is the current thinking for women who've had breast cancer and gone through all their treatments, and then perhaps are then having a lot of symptoms? What is the thinking around them taking HRT? And obviously, I know it's a very nuanced and individual discussion, but there used to be this absolute like, no, you've had breast cancer, that's it, you're never allowed HRT. What is the thinking currently?
Well, I think, listen, what most women experience is still total roadblock and not even an intelligent, informed decision or even an ability to even have a conversation. They're just like, no, I'm not talking about this. No. I mean, that's really what most patients get. But it's interesting. I just actually downloaded the Menopause Society here in North America, their updated 2024 slides, literally just this morning. And I was really pleased to see that they're now making official references and they've had it in their position statement for a while, as had the British Menopause Society. That does make it more nuanced, saying that, listen, we've got, insufficient data and not perfect data on the use of hormone therapy after breast cancer, right? We've got a lot of observational data, over, 25 published studies over the last few decades, many of which are smaller sample size. They didn't follow them for huge amounts of years, but showed no increased risk of recurrence or death. We do have one study, the HABITS trial, which was insufficiently powered and was stopped short, that showed an increased risk of a local recurrence or a new primary, but not a distant recurrence or mortality. And that was a randomized study that, again, was stopped early. And at the same time, there was another randomized study called the Stockholm trial. These are the big ones that people talk about. So that's why I mentioned that showed the opposite, that showed there was no increased risk. And they followed those women, even though they stopped it early. They followed them at 4 years, 8 years, and 10 years and saw that those results held. And that's what's supported by a lot of our retrospective reviews and our observational studies. But what I'd say is the data's not perfect. There's a lot of holes in the data. And so it leaves people really uneasy, right? When we look at subsequent meta-analysis of the available data, what's interesting is, when you really sit down and look at it, most of the meta-analysis basically report that the overwhelming evidence does not suggest that there's an increased risk of recurrence. When they look at receptor statuses, in the studies where they were able to find, because some of these studies were old, whether they reported an ERP or positive, they do note that with women who are estrogen receptor negative, that there is no data points out there that showed that there's any increased risk of, breast cancer recurrence, once these women were properly treated, compared to women who have not used hormone therapy. And so I'm seeing a little bit of an opening now, and that's what I saw in the menopause slide deck that they just released, that they actually have an official kind of wording there that after 5 years of being disease-free for estrogen receptor negative patients, because we know for ER negative patients, they're most likely going to recur in the first 2 to 5 years. Once they're out of that 5-year window, their recurrence risk, stays low, that it can be considered in them. And then for ER positive patients, frankly, and this is kind of I think a nuanced wording, but people don't actually read the position statements. They just have knee-jerk reactions. They say, if a woman who is completed a breast cancer treatment, her non-hormonal options have not worked for her, she wants to have a discussion, it should be an individualized, nuanced discussion with her oncology team. And so that's, I think, how it's moving a bit, but it takes a long time to change doctors' minds, right? And I would say in my experience, most breast cancer survivors are not even seeking HRT, right? They're not. Um, but for the ones that are, they're often very motivated. They are very knowledgeable. They've tried it all. They've tried the non-hormonal stuff and the lifestyle things. For those who have not, we always try to start with the big toolbox of how can we help you? And a lot of times there are a lot of ways that we can help patients with their concerns, not only symptoms, but also things like heart disease and, osteoporosis and bone health. There's many strategies here. But listen, there's a proportion of patients who are just like, I get it. I have an extremely low risk of recurrence, and this is my quality of life. And I either was on it before and I felt so much better that I know I'd like to go back on it, or I've suffered for this long and I'm done. Like I choose this. And I have many women say, I would rather a better quality of life, and I'm willing to take that risk. But the problem is I feel like that option of who gets to decide that patient's autonomy for her body as a cancer survivor is taken away from her. She's not given the choice. She's not even given a discussion. And if she chooses it, I see patients getting fired by their oncologists. Today, one of my friends and colleagues, she wrote to me because I referred her a patient who I wasn't licensed in her state, so I sent her way. Early stage breast cancer patient, very well informed, treated, very, very low risk of recurrence, really suffering and really wanted to have low dose estrogen and little progesterone. And so she started on progesterone only. And then just recently, she was doing great and sleeping. And just recently, she started on like the lowest dose patch. And it's really, really helped her. She saw her internist. Her internist didn't say much at the appointment. And then the next week, she got a letter saying, you've been expelled from the practice. You need to seek someone else because you're not following evidence-based medicine. And they fired the patient for the practice. I see that with some of my patients too, where their oncologists are like, well, if you're going to do this, you got to find some other doctor. And I am like, and it happens more than you think. And I find it interesting because I don't see many doctors firing diabetics who aren't exercising and eating well, or firing their hypertensives or cardiac patients who maybe aren't doing, the right things with their medications. But we feel it's okay to fire a woman who's made like a really informed, educated decision and is caring about her quality of life and her bone health and other things. I mean, how is that sane?
Yeah, it's absolutely crazy. Corinne, what do you think the unique challenges are of the younger female going through an early menopause? Do you think that they have slightly different symptoms or they present differently?
They do. I mean, so the data is really clear that regardless of the cause, whether it's breast cancer or not, although I would argue whenever cancer is in the equation, there's just such a heightened stress and other concerns going on that it just makes everything worse. But remember, these younger women, not only obviously fertility concerns, but we know their symptoms tend to be worse. Like, and I know you didn't have hot flashes, but you sound like you had a lot of other things, right? But tends, when it's abrupt and when it's younger, the hot flashes, the vasomotor symptoms tend to last longer or more severe. So the earlier they come, the stronger they are. The data shows the longer they last. Um, and so their impacts on their quality of life is worse. And I think that their impacts on their sexual health and their relationships, and I don't want to minimize it, that's not a problem for older women. But when you got young women who are either in relationships or still in the dating world or, navigating marriage, um, when you rip away her sexuality by taking away her hormones and not addressing it in any other way, that's really impactful. These women with early menopause, they're also in the midst of often either they're climbing the corporate ladder, they're in the middle of their careers. And so all of their symptoms really negatively impact them kind of financially and in their career. Um, they have a much higher risks of mental health issues due to the complicated nature of their menopause. And so this is why I always say these women have the most to lose and the most to gain, if we could help them. And what makes me really sad is that even for the women who we don't recommend systemic estrogen therapy for, right? Not all breast cancer survivors would we recommend it for, but we don't even offer them like vaginal estrogen. And that's what really makes me super angry. So I always come back to that. I'm like, please at least get that, right? Um, and so, yeah, they really need to be elevated and treated with, the urgent needs that they have. And they need to be thought of holistically because these women, early stage breast cancer incorporates stage 1, stage 2, and stage 3. That's all technically early. Most of these women survive their disease, right? Most early stage breast cancer patients do not die of breast cancer. They die of heart disease. They die of hip fractures down the road. They might lead a life of diminished health span, right? And who gets to decide how they manage those risks? It's quite a challenge. And I don't want to harp on only cancer. I think there's a lot of premature menopause out there that's not cancer related. Those women are as poorly treated as the cancer survivors.
Yeah, absolutely. And so let's talk a little bit about genitourinary syndrome of menopause. I do feel like sometimes it's sort of described as just a bit of vaginal dryness, which makes it sound like this really benign thing, like, just put a bit of Vaseline on your lips and you'll be okay kind of thing. Can you explain what that actually can mean for a woman?
Yeah, and so this is why the medical societies came up with the name of genitourinary syndrome because it is a syndrome. So I always, so we can talk about what's happening in the vagina, and then I just remind patients what's happening there is happening in the vulva, in the clitoris, in the urethra, in your bladder, and in your pelvic floor, right? This whole organ system. And so what's happening is the loss of estrogen causes, loss of collagen, loss of moisture, loss of blood flow, loss of skin thickness, elasticity, nerve endings. So basically, things are getting thinner, shriveled, drier, right? And so obvious things, vaginal dryness, of course, painful sex. Why? Because not only because there's less lubrication. And why is there less lubrication? Because there's less moisture being produced, but there's also less blood vessels there to bring in moisture, and there's less sensitivity to the tissue. So it's not as pleasurable. So you don't get stimulated to actually produce, lubrication. The vagina also gets shortened and thinner, so that adds to pain. But it's not just the vagina. So when we call it vaginal atrophy or vaginal dryness, and we recommend only a vaginal moisturizer or only a lubricant, which those things are fine. I'm not against those things. They're going to be they're comfort measures, right? But a moisturizer isn't going to bring more blood flow to the tissue. It's not going to protect the urethra, so the dryness in the vagina is also happening in the bladder and the urethra. So the urethra is getting shorter. It's getting less resilient. So little bacteria can crawl up the urethra a lot easier. The bladder is, really less healthy and doesn't hold the urine as well. So you get that urge to pee or more frequency, more urinary tract infections. And, you know, the clitoris is also affected, and people don't think about the clitoris because we can't see it. But the clitoris is a highly vascular structure, and we just see the little tip of it visually, but it lives right underneath the skin of the vulva, right? So that whole area is being affected. So patients wonder why my libido's low, Dr. Menn. It doesn't feel as good. I can't have an orgasm. It's not as pleasurable. And so some of that is from directly the clitoris is shrinking. It's called clitoral atrophy. You could also get little adhesions or tissue that basically is like almost like getting scarred down on the clitoral hood as the tissue gets very thin, right? So you put all of those things together and then you think, well, what does that do to a woman's body, right? So now she can't have sex. Sex, when she has it, it hurts. So then I tell women, your brain is your biggest sex organ. So if you're worried about libido, we have to treat the pain points, because if something hurts or if it just feels kind of like not so good anymore, your brain's not going to desire to have that activity. So then that's really affecting your libido. Um, and then the psychological impacts of feeling guilty, avoiding intimacy, whether it's with an established partner, being afraid to be in a relationship, because goodness, if we have sexual activity, then it's going to hurt me, or I might bleed, or, I'm going to cringe, I'll tighten up. And then the muscles in the pelvis then tighten up, and you can get muscle dysfunction in the pelvic floor, leading to more discomfort. And so this is why I get very frustrated when people just say it's a little bit of vaginal dryness, right? And then the urinary stuff, to go back onto that, not only are urinary tract infections, a big problem for women, especially as they age, but just a woman who's already not sleeping well and now she's got to get up a couple extra times to pee at night, just treating that with a little vaginal estrogen, which gets into the bladder and helps improve all of that, can be a real game changer. And so if we can just treat one or two pain points for a breast cancer survivor, we can really improve her quality of life in a lot of other kind of downstream ways, right? And so when patients are told only a vaginal moisturizer, I say, well, did you ask your doctor how that vaginal moisturizer or how that coconut oil is going to improve my bladder wall or restore my clitoris or, help with, all of these things that I just reviewed? And the answer is they're not. Like, coconut oil is not the solution here. It might ease comfort. And if it's working enough for you, good for you. I'm glad. But for most women over the long term, it is certainly not the answer. I say it's a trifecta. You need a moisturizer. You need the vaginal hormones back. So either vaginal estrogen or vaginal DHEA or even local testosterone can be also helpful. And then a lubricant. But a lubricant is for friction. Estrogen or vaginal hormone is going to truly fix the problem. And a moisturizer is just like nice. We put a moisturizer on our face. It does a temporary measure and it's comfortable. So we need to use all three. And if we only use one, or we tell women you can use vaginal estrogen, but first you have to fail the non-hormonal. So that is also just absurd. So we have something safe. Basically, we're saying, patients, we have something safe that I can prescribe to you. And it's safe, but I'm going to make you suffer and use something that only kind of gives a little bit of comfort, but doesn't really treat the problem. And you've got to use that for months to years until you finally come back and beg me. And I say, okay, fine, I'll give you what's also safe. I'm like, it's super backwards thinking, right?
And the thing is, I know that you guys have the same in the US. Here in Australia, we have a leaflet inside either vaginal estrogen and also inside vaginal DHEA, which lists this very scary list. And the number of women, even though I go through it all, they'll often phone the clinic afterwards and they'll say, I've actually read the leaflet and I'm a bit worried because I've got a fibroid, or I'm a bit worried because my mum's brother had a clot or whatever. And it's just, that leaflet is so frustrating. And I think it's really interesting. I think it's seems to be the most read leaflet inside a medication ever. And yet it seems to be it just feels like it's nonsense. It's so frustrating.
It's inaccurate. We have a big movement here now called Unbox Menopause, where we're trying to get that part of the label removed from vaginal estrogen. That's step number one. Step number two is to just remove the black box warning on all estrogen products and just actually replace it with accurate information. Because right now, that black box warning that is on all estrogen containing products, from birth control pills to hormone therapy to vaginal estrogen, is totally inaccurate. It doesn't actually reflect the latest data or the actual data. And I think which is so frustrating for physicians, understand this, is that vaginal estrogen, I like to use this as an example. We can give somebody a Benadryl pill, right? Benadryl diphenhydramine, right? An antihistamine pill if they have like a big allergic reaction or to help them sleep, which is not a great idea to help them sleep, but whatever. So that's systemic. That's a pill. But you can also take a little Benadryl cream to put on an itchy rash on your skin. Two very different things. Or you could take prednisone, a steroid pill, for lots of reasons. We might give someone an oral steroid, works all over your body. Or you could go to the local drugstore and you get a little cortisone cream and put it in cream. Does anybody with common sense think that that cortisone cream has the same impact as an oral steroid pill? No, right? But somehow we make people think, and we have this label that vaginal estrogen cream, which is just treating the skin down there, being absorbed into just that little local tissue there, is the same as taking systemic estrogen. And when you explain to people that a year's worth of vaginal estrogen, taking vaginal estrogen an entire year, is less estrogen in your body than taking one single pill of a 1 milligram estradiol tablet. Now, is anybody afraid to take one pill of estrogen one day ever? No. Why would you be afraid of vaginal estrogen? It's so absurd. And that gatekeeping leads to such tremendous suffering. And it's so horrible. And not just the breast cancer people. It's often, like you say, in women who are just like, oh, I read this and I have a family history of breast cancer, or Uncle Pete had a blood clot. They think, I can't even take vaginal estrogen. But guess what their partners are taking? They're popping Viagra like it's going out of style. And we wonder why there's a couple mismatch there. Sex hurts for her, and he has like an erection on demand. And we wonder, why is there a breakdown in things, And that's another big problem, is that we're only addressing the sexual health concerns, in this case, this clinical scenario, of only one side of the partner.
Yeah, absolutely. I want to ask you a couple of gynae questions, if you don't mind. So first one is, if you have fibroids, is there a reason to be concerned about hormones? And the other one is, if you are someone who's already got some diagnosed prolapse, is using vaginal hormones going to help that?
So fibroids, no. You should not be afraid of vaginal hormones or systemic hormones. I mean, if you're having abnormal bleeding that's not been assessed, you always want to get that worked out. But if you've got established fibroids, they're stable, you're doing fine, or you had them and now you're menopausal, one systemic hormone therapy is not going to make them regrow. So if you take an estrogen patch or a pill, it's not going to make the fibroids regrow. Certainly vaginal estrogen is not going to touch them. No. If you've got a prolapse where the vagina or the bladder is pushing into the vaginal wall, vaginal estrogen is not unsafe. And in fact, a lot of women in the menopause who have prolapse, the prolapse is often due to reasons like they've had multiple babies and there was a lot of pressure and damage to that pelvic floor, or they had surgery. So there's a lot of kind of stress that was on that tissue that caused that prolapse, and some genetic reason. So then when you add on top of that menopause and the breakdown of collagen and support and elastin, the lack of estrogen can make it all kind of worse. Now, if you've got a real physical prolapse, vaginal estrogen is not going to cure it, but it's certainly not going to be harmful and may even help the tissue quality, right? So those are two super easy clinical scenarios where, of course, they should be able to have it.
What are the numbers or statistics for people having premature ovarian insufficiency and early menopause? Do we know, like, if you had 100 women, how many would have sort of an average menopause and how many would have a very early and early?
Yeah, so the numbers are funny. When I try to look these up, like there's this widely quoted 3% of women will have premature ovarian insufficiency. I suspect that 3% number comes from true premature ovarian insufficiency from either spontaneous, genetic causes, autoimmune issues. I don't believe that number captures the number of women who have premature menopause for iatrogenic reasons, meaning medically induced reasons. We know the numbers are greater, right? There's millions of women dealing with breast cancer diagnosis. There's millions of other women dealing with other cancers that cause early menopause. There's tons of women who have surgeries for other GYN problems that have early menopause. So I think the number is a lot greater than 3%, but that's what's quoted. Interesting, one number is in the US that 1 in 8 women will lose their ovaries prior to the age of natural menopause for benign reasons. And I suspect that number is going to grow because we've got more women preventatively removing their ovaries for hereditary cancer reasons. Um, so that's a large number right there. And in a recent published journal article that was just last year, when they looked back at what was the trend in how these women, not cancer survivors, but benign reasons for early menopause, what was the trend in hormone therapy use? It had substantially declined over the past 20 years, and it had reached its lowest levels in recent years of less than half of these women are offered the standard of care, which is hormone therapy. And if they were offered it, it was for less than 6 months. And I think like less than a third were offered bone density testing, and even less were offered routine cholesterol testing. So those are some numbers that give you like a really shocking analysis of, you know, what women are facing in the US. And I don't think it's any better in the rest of the world.
No, absolutely. I had a patient in the last few weeks who actually had undiagnosed celiac disease, and she's got a POI. So very interesting association with.
Well, because because celiac has autoimmune associations with it, right? And so we think there's a lot of overlap in patients with POI and autoimmune. And some of that may be increasing because of environmental factors too. We don't know. And that's a great point, actually, that there's all of these women who no one's looking out for, that they should be clued into. Like, well, you've got celiac. Do you know that that's associated with an earlier menopause? And that's another important thing. So women should get a heads up on what to look for. And, they don't. So it's this idea of educating women about perimenopause and menopause way before it actually typically happens, so that they know what to expect. And so if they're starting to get some of those changes, they can speak up and say, hey, that's also happening to me. Maybe I need to get this checked out.
Yeah, I agree. I think I'm all for the movement of trying to pull the conversation back at least 20 years, because I think then you wouldn't have women so shocked. The other question I wanted to ask is the association between hysterectomy, so having your uterus removed, but you've got your ovaries left behind. But aren't we understanding now that actually the removal of the uterus probably puts you at increased risk of an earlier menopause than you would have otherwise had?
Yeah, the most recent published data suggests that up to about 3 years of having earlier menopause. And why is that? That's because the ovaries get their blood supply from the ovarian artery, but also from collateral blood flow from the uterine artery. And so when we remove the uterus, we clamp off the uterine artery. So it's already getting diminished blood flow from less blood flow from there. It's still getting its main feed from the ovarian artery. So that's one proposed reason why there might be diminished reserve. There could also just be other, blood vessels that are, damaged or impacted by surgery. But the problem is that those women have had their uterus removed, so they don't have the telltale sign of menopause because they don't get periods anymore. And that's fine. Like, listen, a lot of them have their uterus removed. Maybe they had horrible bleeding, they had horrible fibroids, they had endometriosis, and this really improved their quality of life. So I'm not saying that's a problem. That's good. Have your surgery for indicated reasons. But we should let these women know that not only is that if it's coming 3 years earlier, then that means their perimenopause is then earlier. And we know perimenopause could last quite a while. And so because they don't have this sign that their periods are getting less, they often say, well, I thought I was just got an anxiety disorder, or they're writing off their joint pain and their weight gain and all these other things. And people say, oh, you're too young for menopause. Well, no, they're not, right? And it's actually not something that is in a like a lot of patients tell me they were never the time of consent, informed consent, no one told them that that's something to look out for and to be aware of. And that's a shame.
Yeah, absolutely. And Corinne, what do you think about like what message would you love to get out to patients and I suppose their doctors if you're going to have breast cancer, maybe therapy, chemotherapy, maybe you're going to have surgery. What do you think patients should be told about menopause before they embark on those treatments?
Yeah, so it's a good question. Well, I tell patients survivorship starts the day that you are diagnosed, that's when it starts. And so it's very overwhelming because you're getting a lot of information put at you. You're having to make surgical decisions, chemotherapy decisions, other treatment, decisions. And so I know it's a lot to ask you to have to do, but you have to understand this is a serious diagnosis and you're likely to survive it, but it's going to impact the rest of your life. And so from day one, you really have to always be asking the questions and educating yourself on like, what are you doing to treat the whole person? And you have to demand that you get information or educated on what are you going to do about the estrogen deficiency that is going to be caused from my breast cancer treatments. So the British Menopause Society did a very, very good professional practice statement on this that you can Google it. Anybody can get it. It's open access. And it's actually very, very good. And it says all women prior to starting their treatments that might cause estrogen deficiency should be referred to a menopause specialist so that they can go over, what to expect and what their proactive preventative strategies and options are. Because many times we can manage these patients even without hormones, but we need to do it proactively and holistically and not having to a woman finds me after a decade of suffering and she's sobbing at her appointment because her whole life has been broken in all these other ways and everyone's just been written it off. So that's upside down medical care. So I tell patients, listen, you may not get those answers all at once, but it has to be part of your kind of plan. And you've got to be the CEO of your health immediately. And then from the doctors, I have to say, if you're listening to those doctors, if you're not a menopause specialist, you don't know about sexual health, you don't know about preventative health, chronic disease management, that's okay. You didn't get trained. It's not your fault. But guess what? Time's up. Time's up. We've got something called the internet. We've got menopause societies in every country. We've got practice guidelines. We've got a lot of systems. So if you don't know how to deal with this and you're giving patients medication that's putting them to menopause, it is medically your responsibility to be addressing that, And if you need a good resource, my favorite resource is Danny Bennington out of the UK. She's got a website called Menopause and Cancer, and it's an incredibly helpful, patient-friendly, but also very doctor-friendly for all women dealing with cancer and menopause. I just can't speak highly enough of her and what she's put together. That's a great starting point. Download the British Menopause Society statement. Those are my two favorite go-to references to at least get started. And you got to be the squeaky wheel. And if people aren't taking you seriously, you have to ask for a referral or get a new team. It's a lot of work, though. It's exhausting.
Have you any, just my second last question is, have you any thoughts as to how we get male clinicians to have a little bit more of an interest in this subject? I know there are some really amazing male clinicians, but some definitely aren't interested. Do you think there's any way we can motivate them to get on board a bit more?
I really think patients and doctors who are trying to advocate for patients, I think it's really important to try to reach out to them on a one-to-one personal level. When I pick up the phone and I'll call an oncologist, I'll be like, listen, I get it. But here, I just want to share with you, this is actually what's happening to her, right? And, appeal a little bit to their better angels and say, listen, can we think a little bit more holistically? And, when doctors generally don't go into medicine to be jerks to patients. That's not why we became doctors. But they're very burdened by the medical system and they're overwhelmed. And so sometimes they just need a little light touch and try to like appeal to them. And then for the males, I sometimes use this analogy of like, listen, imagine I cut the testicles off of your son at 30. I mean, not to be vulgar, but like, let's call it what it is. Could you imagine if I castrated your son or you and asked you how you felt and how you would get on with life? That is what is happening here, And so can we have some more compassion about that? And, I'm like, would you want to have sex if it felt like shards of glass? Can you understand how devastating that is to a woman's life? How would you feel? How would you feel that you haven't slept in 8 years because of your awful symptoms? And say, listen, I can partner with you. I can give you resources. But it's hard. I think we've got to win them over literally one by one. And sometimes I see when I turn one, I'm like, okay. I'm like, well, next time with the next patient, maybe you'll just be a little bit more open-minded. And then, and I tell my patients, you've got to be a squeaky wheel because you're going to make it better for the next woman.
Corinne, you have been amazing. I could talk to you all day. My final question, which I ask all my podcast guests, is if you could talk to your 20-something self, what would you tell her?
I would tell her, I was 28 when I was diagnosed, so I'll picture that. I would tell her, take a deep breath. This is a marathon. It's not a sprint. And it's okay to pause and regroup, reset. And also, I really wished I had done all of the boring lifestyle advice that I didn't learn to do until I got much older. So in the midst of my struggles of cancer treatments and early menopause, I wish I would have said, you know what? I have to lift some weights. I've got to do meditation. I've got to really clean up my diet and I've got to eliminate alcohol. If I would have done those things on a regular basis, I think that even without having the hormones on board, I would have managed things a lot better. But I didn't do any of those good things. I wasn't doing it terribly, but I wasn't doing them the way they should. So it's boring advice, but it really would have been the best advice.
Thank you so much. I've loved our conversation. I hope I can have another one with you very soon.
It was really lovely to talk to you. Thank you so much for having me.
When I started this podcast back in December 23, I knew that I was lucky enough to have amazing conversations with various health professionals across all facets of medicine and allied health. And I knew that you would probably really enjoy being a fly on the wall to hear what we talked about. And that's how the podcast was born. And what you probably don't know is that this is a bit of a passion project. We don't have any sponsors or funding. And without your help, we won't be able to continue bringing you these great guests. So if you can please spread the word about the podcast, share it with someone who you think might benefit from the conversation that you've just listened to, or if you can leave us a review or a comment, it would mean the absolute world because that actually helps the podcast spread further and get more people to hear our message and hopefully allow us to invite bigger and bigger guests onto the show. And I would so appreciate you helping me back. Thank you. This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.